next speaker is Dr. Atul Kumar, who needs no introduction. Is the top ophthalmologist of our country, and is going to be telling us preferred practice guidelines for pars plana vitrectomy. Look forward to hearing from you, doctor.
Thank you, ma'am. It's a pleasure to be in your prestigious ARC course, and I feel honored that you've invited me to be a part of this in the AIOS meeting, which is being held so well by all of you. You invited me to be part of this preferred practice guidelines, which are very helpful, I think, for the general ophthalmologists and also for the residents. So I just talk to you in short, as has been advised. We have a short meeting, a short talk with some discussion, and then the basic principles of vitreoretinal surgery and indications for diabetic vitrectomy. So you got to understand the general ophthalmologist, or for the beginners. For the beginners, it's very important to understand the vitreoretinal surgery is fundamentally different from other anterior segment and other microsurgeries. For that matter, even strabismus surgery, that the posterior fundus is not visualized, is impossible to visualize until you have adjuncts. So those adjuncts can be in the form of certain contact lenses, like here you see the flat lens, the Chalam lens from KV Chalam, Indian, who settled in the US, who's got these four flanged contact lens, which neutralizes the corneal power of 44. And so you can visualize the retina magnified in the center, which is about 30 to 50 degrees, and you can move the eye to see the mid periphery. So this Chalam lens is of great help because it keeps the lens anchored onto the cornea, because the flanges prevent the lens from slipping away. So this kind of adjuncts really help. These are other adjuncts which increase the illumination or give you a double. You can do bimanual. Otherwise, all vitrectomies are one-handed. One-handed means there's only one active instrument. The other instrument's holding the light. The light pipe instrument is a passive or a non-functional hand. It could be your left or right hand, depending on whether what kind of surgery you're doing. And so putting a fourth port is a chandelier light, which I often do, and I recommend a lot that you should get used to using the chandelier, and buy a machine which you have a facility to attach a separate light, so that you can do surgery with both active hands. And then another thing very important is the previous lens I showed you was only for the macula. But then you need a lot of panoramic viewing for the retina, because you want to see the retina of the giant tear, the periphery, what's it showing like, and what's the 360 degrees, what's at 9 o'clock, what's at 12. So because diabetic eyes or detachment eyes or many other eyes, you have various findings which may be missed on until you don't have a wide angle viewing system. So you can have a non-contact wide angle viewing. It's also called waves wide angle viewing system. Non-contact, which is like here you have the read sight attached to the no financial interest to the Zeiss microscope, or you have the contact wide angle, like you have the mini quad XL from Vogue. And so all vitrectomy machines, for a beginner or for somebody who's going to invest, for a resident who's going to go into practice or wants to buy an equipment for his eye center, he should have a linear suction cutting available in the machine, or a dual dynamic drive. He should have a good illumination, a xenon light or a LED light. He should have a facility for vented he should have a viscous fluid injector. That means oil should be automatically injected and extracted. And then you've got a duty cycle control. I'm not going to the details of this. What happens is, when you're at a very high cut rate, the port should not close. So it's an open bias and closed bias duty cycle, which you have in some of the machines, in which the port will not close despite you're working at very high cut rates. That's a duty cycle control. The flow and suction control should be there, and vented gas force infusion is something. Gas is forced through the infusion bottle, which is maybe BSS plus, like I use BSS plus, Alcon. So the vented VGFI helps you to increase the IOP from 15 millimeters mercury fluid pressure to 60. So I can stop the bleeders in cases of diabetic vitrectomies, which we do a lot, which I like to do a lot, which I do a lot because of the number of cases. And if the air pressure is 40, then of course it goes up to 60. So the VGFI can be switched on and off. Don't keep it on for too long because you might get disc pallor. And then you got a built-in laser. If it's you really want to go in for a high-end machine, you better have a built-in laser because that really helps you to work through a single machine and a lot of ease, patient-friendly, surgeon-friendly. So I'll go fast now. So you have these dumbbell-shaped cutters. They kind of fit into your fingers, and your fingers are resting here. So the back part of the cutter is a little swollen up or a little wider, so that it won't slip through. So this is a very nice, and they're very very light probes. They're some kind of a acrylic or some plastic which they use, but these are basically you can do plasma sterilization or ETO, and they very lightweight. They often have a stiffening sleeve because you use these MIVS cutters, 23, 25, 27. So they have a stiffening sleeve so as to prevent the shaft from getting bent. Surgical, actually for us, like in RP center, we have this surgical skills center, which I feel that because this kind of a lecture, the ARC guidelines and preferred practice patterns for the newer beginners and all, they should really practice. And we have these facilities. We have the phaco facility as well as a simulator for learning retina surgery also. So this is IC simulated by VR Magic, where we train our residents to use peeling the membranes or using as if they're using a cutter. It's like sitting in a artificial cockpit and seeing the plane fly. So you can sit here and do the work. Of course, it's a little expensive, but good for sectors. So to start with TechMe, you got to have a four limb surgery.
Please conclude the.
Yeah, sure. So this is how you make the entry point. I'm just finishing in half a minute. So you go in tangentially and go in vertically then. And you endolaser around the break. And these are cryo probes which you should use very carefully. It should only freeze the tip, not the shaft. Because there's a recent case where I saw a cryo burn of the lid because the shaft may have frozen, done somewhere else. So oil or gas is something which you use as a substitute. And this is how we fill up the gas at our place. Or the oil is the vented forced VFI. And this is how we
I
operate.
request you to conclude the session.
Yes, we would. Now, don't keep talking now. Just let it be. Yes, doctor. Continue.
Yeah. So this is now we've come to the 23, 25, 27 gauge vitrectomy. And these are closed systems and very good because they're like a laparoscopic surgery. And the wound heals up very well. There's no astigmatism, no dry eye. And we go transconjunctival. So we don't call it transconjunctival or stress. We just call it a MIVS, minimally invasive vitreous surgery. So it really it's of great help. And now I use this, like I told you, this is just the last slide which I like to show you with the, bimanual surgery, because you've got to have a light pipe, a separate chandelier. So this is a case done very recently. So you see, I'm finishing in just about 15 seconds. So part of the vitrectomy, I like to see if I can peel off, because the cutter itself can even help with the suction. You can peel off a part of this fibrovascular tissue. There's a taut posterior hyaloid with fibrovascular tissue. So part of it I release and segment, and part of it which I cut. So here I'm using a 27 gauge cutter. I use a lot of 27 gauge in diabetic vitrectomy. You can see as I'm making, I'm passing the cutter between the correct plane of the retina and the overlying tissue. So it helps me to avoid breaks with the 27 gauge cutter, the narrow port, and also to segment the tissue. So you got to segment tissues to relieve the traction. This is what I like to do, and this case did very well. And this was the first day post-op, and he improved to 636, and now actually it's 612. Thank you so much. Sorry I took a little extra time.
Thank you. Thank you very much, doctor. Just one very general question. When you're doing a fluid air exchange, if the posterior surface of the IOL starts getting very foggy, how would you deal with it?
I just put in a little viscoelastic drops, couple of drops of with the cannula, bent cannula. I take viscoelastic and I go through the parts through my cannula, the trocar cannula, and I just put couple of drops behind are drying of where it's drying, and just the whole thing spreads out and the drying gets taken care of.
Dr. Srinivas, any question for sir?
No, sir. Wonderful videos, Atul sir. You described it so nicely that even a common ophthalmologist or general ophthalmologist could understand it so well. I have seen your videos. Wonderful.
Thank you,
Thank
sir.
you. Thank you. We are enlightened to have you with us today. Thank you, Doctor.
Thank you, madam.